Abrindo aqui o YouTube. Eu vou te mandar o link para você ver o que está sendo colocado lá. Aí, Vlad, sabe o que eu ia te pedir? Tu pode acompanhar o chat do YouTube e ver... Ó, vou te mandar o link e vou te mandar no teu zap o link de transmissão do YouTube, para tu compartilhar aí.
Está faltando só 9 minutos, viu?
Eu tô vendo aqui. Dr. Gaston. Hi, Dr. Gaston.
Hello. You can see me?
Yes, I can see you. Very well.
Oh, it's a pleasure. It's a pleasure to meet you. Yeah. Hello?
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 Yes.
Hello. How are you? The connection is okay?
Yes. The connection is okay. Yes. I'm here. Nice. Very nice. And you?
Fine. Yes. You know, I am confined. I am in my house in front of the sea because it's impossible to work in Bordeaux today. I just do 3 surgeries in a month because we have to close the operating room due to the COVID. And it's just possible to treat cases in emergency or to treat very hard case of cancer, especially kidney cancer.
Okay, very nice. We are now almost starting the meeting.
I can see you. Okay, wonderful.
I'm here. We have right now Dr. Mauro Rosa Almeida, Dr. Ana Carolina, Dr. Vladimir,
you are in the hospital? You are in the hospital?
No, I'm in my house. Everybody is in their house.
Is it possible for you to work, or the surgery is cancelled?
The surgery is canceled. Now we are doing just urgencies and also oncologic procedures that cannot wait. But for example, only prostate high risk and things like that.
Good evening, Professor.
Oh, good evening. It's a pleasure to meet you.
Pleasure to meet you.
Yeah. We are living a very strange period, and you know that in France we have more than 20,000 deaths. It's a really a disaster. In Bordeaux, we have a few cases. In Bordeaux, we have few cases, but the majority of the cases are in Paris and in the northeast of France. And
I see.
yeah, I stopped to do prostate surgery, except for height level. When I have confined in the pelvis. Hello, how are you?
Hello, Mr. Gaston.
Hello, ça va?
Ça va très bien.
Bon, tu es chez toi, tu travailles?
Je suis d'astreinte, là j'ai une Gigi à faire, mais je veux peut-être profiter un peu le temps en attendant.
Ah, écoute, c'est sympa. Nous, on a complètement arrêté. Tu vois, je n'ai pas opéré pendant 3 semaines. 3 semaines.
Oui, ça doit être dur.
Ah oui, c'est très dur, c'est très dur. J'ai juste fait quelques grosses tumeurs du rein et demain, je fais des glissons 4+4. Je fais 2 prostates curage. On va recommencer petit à petit, je pense. On va recommencer.
Bah oui, il faut, hein, parce que on trouve pas mal de surprises, même pour les T1A du rein. Dans 3 mois, ils sont métastatiques. C'est très bizarre, mais je crois qu'on est dans la perte de chance pour les patients quand même.
On a beaucoup de lésions, de tumeurs de vessie là, qui étaient en attente.
Ouais.
J'ai beaucoup de cystectomies à faire là, dans les semaines qui viennent.
Ouais, bah, si vous avez de la place, très bien, mais la situation au CHU, c'est un peu compliqué, quoi. Pour les places, surtout au robot, c'est compliqué.
Ah oui. On a une salle de robot. Je pense qu'ils vont ouvrir une salle de robot la semaine prochaine. Une autre salle de robot à mi-temps.
Ah oui, un 3e.
Allô?
Yes, we are here.
Yeah. What do you want to know? How we are living the crisis in France?
Yes, the idea is take your experience from this crisis. What cases you are doing, and what your advice is for minimally invasive surgery, and you're gonna have 8 minutes to speech, to talk for us your experience. After we're gonna have a RAYAN. He's gonna talk about 8 minutes.
So I have 8 minutes. 8 minutes. You want that I speak about the situation in France?
Yes, that's the idea.
So I can give the example of my institution. So
perfect.
We cancel all the surgery, and we just choose the biggest case in oncology, renal tumor. When the tumor is bigger than 7 centimeters, or when
Dr.
there
Gaston,
is a
Gaston.
Yes.
Sorry. Because now we're gonna just open the section, the meeting.
Okay.
I'd like to give the word for Dr. Vladimir Pinheiro. Dr. Vladimir Pinheiro, he is the chief of the section of uro-oncology in our department. So he's going to open the meeting, talk with the audience, and then you're going to start. Okay?
Okay.
Vladimir?
Del, vamos começar, Del? Já temos...
Eu acho que a gente pode começar. Deixa eu só falar uma coisa para eles. Dr. Gaston, Andrea and Ryan, I will try to translate a little bit after you finish your talk, because some of our colleagues, they not speak very well, and maybe don't understand everything. So just
So you prefer?
try to help them.
I can speak in French if you prefer to translate.
Maybe
as you want.
Going to be hard to me.
Okay,
but
so
I
you
think in
prefer
English
that
is
we
okay
speak
for
in
everybody.
English. So you know, we are confined in France from the 17th.
Just a minute. I think Dr. Vladimir is going to talk something. Just a minute. Vladimir, acho que a gente pode começar.
Podemos começar?
Opa.
Podemos.
Eu já te passo, Idel. Temos 25 participantes, o pessoal já tá entrando. Eu só quero dizer que hoje é terça-feira, é mais uma sessão da divisão de câncer urológico da Santa Casa, né? Quero agradecer aos coordenadores que proporcionaram esse momento tão importante para a gente, né? O doutor Rômulo Silveira, o chefe do serviço, a doutora Karine, o doutor Maura, a doutora Carol, o Fábio Nácia, o Fábio patologista, está todo mundo aqui. E é um momento importante porque a gente está vivendo realmente um momento de problemas em termos dessa pandemia, que talvez nas crises sanitárias que já teve desde 1918, nunca tivemos realmente um momento em que mudou realmente a geração, né? Então, a sessão da Santa Casa de Fortaleza é uma sessão hoje forte, um grupo forte, no tratamento de urologia de uma forma geral, e principalmente na área de câncer urológico, a gente tem essa sessão semanalmente, e vamos discutir hoje, vamos deixar a coordenação através do doutor Idelbrando. Ele vai fazer, depois de cada comentário dos palestrantes, um resumo em português, tá? O doutor Idelbrando fala muito bem inglês e tem essa maneira de interlocução muito fácil. Ele vai fazer realmente essa moderação. Quem quiser perguntar, é bom que os microfones estejam desligados. Quem quiser perguntar, tem a opção do lado do microfone da mãozinha ou no chat. A doutora Ana Carol Queiroz vai coordenar isso daí em relação às perguntas, tá? Então, está aberto para os painelistas. A gente vai ter hoje a participação internacional do doutor Richard Gaston, que realmente é uma das maiores autoridades do mundo em cirurgia minimamente invasiva. Vamos ter o doutor RAYAN, doutor ANDREA e o doutor FRANCESCO. Então, o doutor Idelbrando pode fazer um comentário específico de cada um, apresentar melhor que ele conhece todos eles e trabalhou com eles. Vamos começar a sessão. Doutor Idelbrando, com a palavra.
Um prazer grande da gente estar aqui hoje. E nós temos alguns convidados aí que são grandes professores e grandes amigos. Nós vamos começar com o Dr. Gaston, e eu vou fazer um pouco do mix aí, inglês e português. Dr. Gaston, thank you very much to join us in our meeting. It is a very good pleasure to be with you. And also an honor to have your advices and to know about with someone like you. So the word is with you.
Oh, you know, it's a great pleasure, great pleasure for me to be with you, and you know, I never forget your stay in Bordeaux. It was for me a great honor to receive you in Bordeaux, and it's always a great pleasure to speak with my colleague from Brazil.
Thank you very much, Dr. Gaston. You can start. It's nice to know how is the situation in France, how is the situation in Bordeaux, if you are operating right now or not. Your advice is for minimally invasive surgeries. You can start.
Yeah, okay. So the situation is clear. we are confined from the 17th of March. We have the government have decided to stop the conventional activity in all the big centers, in all the hospital. We have decided to stop the activity from the 17th of March to have hello, Marcos. Marcos.
Yeah, Marcos is here with us.
Yeah. So
if you can,
so we stop the conventional activity, and we have received instruction from the Ministry of Health to treat some patient. And what we have to treat? We treat the big renal tumor over 70 centimeter, 7 centimeter, or even if there is a thrombus in the vena cava, in the renal vein. We can treat the bladder cancer, especially if it's impossible to do chemotherapy. Actually, in France, it's difficult to organize the cycles of chemotherapy. And before beginning the chemotherapy today, we prefer to remove the bladder. So it's possible today to operate a patient to remove a bladder. Another surgery, what is possible to do is the tumor of the testicles. We are doing lymph node dissection, and we are removing testicles for tumor. And the other way is about TCC. When there is a tumor in the ureter, for example, or on the pelvis, of course, we are allowed to operate the patient. And as you know, we do everything by robot. In our institution, normally we have 2 rooms for robot, and from 1 month, we have just 1 robot for 2 or 3 procedures by days. But we hope after the 11th of May to recover a normal activity for all the cancer and all the emergency, especially the stones. But probably we will have to wait July or August or September to treat benign disease.
Okay.
Yeah,
very nice.
In our institution, we have a department of intensive care. We have received some patient with the COVID with high level of reanimation. Have you some question?
So now, no questions from the audience, Dr. Gaston.
No, so we continue. Yes.
I have a question. I didn't understand. So, in case of patients with hydronephrosis and stones,
yes, of course, we can treat. We can put double G. We can put double G to reduce the hospital stay. So
but you don't do ureteroscopy.
Ureteroscopy, double G. So if it's simple, we can do it. But if the stay of the patient is too long, we prefer to put a double G and to C. We treat the emergency, and then we will treat later the problem, especially in this period. Probably in 1 month, the situation will be clear.
Dr. Gaston, this is Romulo from Fortaleza. I don't think you remember me, but I remember you very well.
I remember you. I remember, yes.
Thank you. Dr. Gaston, here we take care of the contamination when we do a laparoscopic or robotic. So almost every hospital tells us to do it open surgery. What could you say so we can change this?
I think it's absolutely a nonsense. There is no difference. We know you know in France, in the great majority of the center, we stop to do open surgery from 10 years, minimum 10 years. So when a patient arrives, we have to see if the patient has COVID or no. Sometimes we do a CT scan to see if there is no pulmonary disease, but we treat the patient by a mini-invasive surgery, of course. No, we never do open surgery except when we have a big mass on the kidney with a thrombus in the heart. But we always do mini-invasive surgery, of course.
All right, thank you very much.
I think it's the main argument is that the recovery for the patient is shorter, the hospital stay is shorter with the use of mini-invasive surgery. If you open the patient, of course, I think he will stay more time in the hospital, and he have much more risk to have a contamination. Yeah.
Very nice. Thank you very much, Dr. Gaston. I'm gonna open for another questions at the end. Now, Dr. RAYAN going to talk. Dr. RAYAN is a very good friend of ours also. We worked together in Clínica Saint Augustin during the fellowship. It's a very good pleasure, honor to be with you and to share your knowledge. He is now in tours, so he's working in a public hospital. We can see now the perspective from the public in France. I think going to be very nice.
Yes.
He prepared the presentation, and I will put here in RAYAN. Everybody can see the presentation?
Yes.
Yes. Francisco, I have connected with 2 accounts actually, and I can share, I guess, the presentation if you want.
Oh,
Let
it's
me
better.
do it.
Yes.
Yeah. Let me know. I will try to share it with everyone. Do you see it now? You can see it?
Yeah, we can see.
Okay, I would like to start to thank you, Francisco, for the invitation. Sorry for maybe I will go a little bit fast because I'm on duty. I have to go to the OR in like 15 minutes because I have a septic shock on obstructive pyelonephritis. But it's a big pleasure to join you, and I'm very happy to see Francisco and to share our experience with you in Brazil. As Dr. Gaston started to say, I will repeat exactly the same. The difference between the public hospital and the private practice is that we have a lot of emergencies. We do a lot of emergencies. Every day we have like at least 12 hours of operating room because we still do, like Dr. Gaston said, the big bladder tumor. We are still doing the mini-invasive approach with the robot because there's small studies that showed that the virus could be dormant in the peritoneal cavity, and the pneumoperitoneum could infect the resident or the assistant on the patient, because when we take out the instrument from the trocar, we can have like a dissemination of the virus. Some studies showed this, but it's not conclusive. And the only idea I want to share is when we desufflate, when we empty the pneumoperitoneum, we do it with the aspiration. We do it with the suction. We don't open the trocar. So we will like protect the resident on the patient and try to decrease the risk of contamination. Okay, so I prepared like a small presentation to try to like a small synthesis of the actual situation in France. I work in a university hospital that drain a big population. It's like it's situated in the center of France, a little bit from north from Bordeaux, and on the south from Paris. Mainly, we drain two regions that called Centre Val de Loire and Indre-et-Loire. Do you see the presentation?
Yes, we see.
Yeah. Do you see the curves or not?
No, the curves, no.
Okay, so there's a problem. Maybe I'll stay like this. Okay, I'll try to stay like this. So here you can see the number of patients that are infected. It's like about 200 cases, around 1,000 cases hospitalized. And on the 16th of April, we had like 200 patients in the ICU. So the important why I'm showing you this curves, because we are starting to see the flattening of the curves. We have less patients in the ICU. Every day we have like 15 patients less from the day before. And in France, they announced it during the weekend. There's a ratio, which is very important ratio during this pandemic, the R0 ratio that we started. The R0 in France were like more than 3. And now it's 0.6. The R0 ratio is the number of patients contaminated from one patient infected. So at the beginning, it was like 3 and more. Now it's 0 point something. So it's natural, it's normal that we are seeing the flattening of the curves. Here we can see the cumulative number in my hospital. We have like 26. I checked a few seconds ago. We have now 28 deaths, unfortunately. And the number of patients in the ICU, you can see that it's stable. The curve is flattening day after day. This is the same curve with the all kind of patients, the patients that were cured from the virus, and we can see that the number is increasing day after day. So Dr. Gaston did a very nice resume of the recommendation in France, because we all received like a recommendation from the French Association of Urology to have, it's very objective. It's like a blueprint. It's not like a recommendation and evidence-based medicine, of course, but it guides us through this crisis to at least do the choice of the patient, what we have to operate and what we don't have to operate. I will start with the kidney tumor, as Mr. Gaston said, and we are doing this also in the university hospital. It's not only for the private practice. So all the T1 tumor, and at the beginning we started to operate even the T1B, but now we are not operating the T1B, even the T1B. So only the tumor that are more than 7 centimeters, the clinical T2. And if you see here, I don't know if you can understand French, but for the T1 tumor, you have to report the operation, but for the T2, you could report the operation. It's not obligatory even to operate on a T2 tumor and on this crisis. For all the T3, the surgery must not be postponed. And of course, for the immunotherapy, in France, we started to give for the high-risk metastatic patient the combo therapy with ipilimumab and nivolumab, and this treatment is now postponed because there's a lot of risk of patient needing ICU after this treatment. So they stopped to do this treatment and they went back to sunitinib or pazopanib. So for the urethral carcinoma, also there's a bladder tumor and the upper tract tumor. For the upper tract tumor, it's like very aggressive disease. We are still doing even the diagnostic ureteroscopy to see if the tumor is a low grade or a high grade. And for the nephroureterectomy, we don't have to postpone the surgery. For the bladder tumor, the low risk non-invasive bladder tumor, we can postpone the surgery. But for the intermediate risk and the high risk, we have to operate. Even for a TURBT, we don't have to postpone the surgery. And for all the invasive bladder tumor, we have to operate them with a delay maximum for 3 months, not more. So this is what we are doing. For the prostate cancer, we are operating only the high risk. Only the high risk, the low risk, and the intermediate risk, we are postponing at least for two months. The docetaxel for the metastatic patient, we are not offering now because the oncologists are not doing any chemotherapy during this crisis. And one idea I like to say for the bladder tumor, usually in the university hospital, we don't have a lot of places in the OR to operate the patient. So we usually benefit from the neoadjuvant chemotherapy for the bladder tumor to delay the surgery and to find a place in the OR to operate the patient after the neoadjuvant chemotherapy. But now there's a big problem because there's no chemotherapy and we are not having the 2 or 3 months delay to operate the patient without delaying the treatment. So for the testicular cancer, we are of course not delaying the surgery because it's an aggressive disease. Of course, we are not doing any partial orchidectomies. And for the chemotherapy, the importance also is they are not giving any bleomycin because it's very toxic for the lungs. So they are switching from the bleomycin to ifosfamide. For the penile cancer, we are doing the surgeries as for the recommendations because usually we don't have the option to delay the surgeries, but we are taking more time to do the status, the metastatic status for the patient with a PET scan or to see if there's infiltration of the inguinal lymph nodes or not. So this is like a small synthesis of the situation in France.
Thank you very much, Rayan.
Yeah.
Thank you very much. Are you open for one question because I know you're gonna leave soon?
Yes. For now, I'm still with you.
Okay, so it's nice. So let's go to Andrea, Dr. Andrea Mari. Are you there?
Good afternoon.
Dr. Andrea Mari is also a friend of us. He is an assistant from Florence, and he's going to talk about the situation in Italy.
Good afternoon. I would like to thank Francisco for the kind invitation, and it's a real pleasure to share the experience, our experience with you. Can you see my slides?
Yes.
Okay, perfect. So I will try to give you a snapshot of the management of urological care at our hospital. It was extremely interesting to listen the French experience, because actually in Italy it's a little bit different, and this difference is related also to the different prevalence of COVID disease around Italy. In northern Italy, as you know, we have a lot of cases, a lot of deaths, and of course, the urological hospitals are all closed, and there are COVID patients recovered. There are many urologists that now are working in COVID departments right now. I would like to I would like to share with you our today update in Italy. We have first of all, we are a nation that is not very big, not very wide, but we have 60 million of inhabitants. It's one of the regions with highest prevalence of inhabitants in Europe. And we had a real spread, as you probably know, of COVID. We registered 25,000 deaths until now, with 100,000 active cases. So the curve is probably going down right now, but the situation was extremely hard. I will try to give you also a snapshot of our region. Well, this slide is taken from our national system organization in Tuscany 10 years ago. We were divided in 12 different departments with 4 big hospitals. The situation completely changed in the last 10 years, probably for to reduce the cost. So now we have only 3 departments, and all patients are centralized in the main hospitals. Why am I telling you this? Well, first of all, also to explain how we are currently managing urological care during this disease, but also because this problem of the centralization is actually one of the most important critics to our government, because there are many people that they were dying, and probably this was also because it was extremely difficult to take care of all patients, because with centralization that is not possible. And we saw that in Europe, the most important well, some countries, the countries with the lowest rate of mortality were that countries that can manage the disease at home, or with a very careful care of patients in the territory. So let's move to my city, to Florence. I'm actually working the University Hospital of Careggi. Careggi is the referral hospital for our region, that is the central district of Tuscany. So actually we are doing we are performing all the robotic surgery. We are actually doing, I will show you in the next slide, all the surgery for all this area and also for this district hospital. So this led to an exponential increase of robotic procedures since we started in 2010 with just 80 cases. In 2018 we performed 1,000 cases, and I think that in 2019 we are around 1,300 just for robotic urological procedures. this is mainly related to the centralization of patients, and also because we reduced a lot open and laparoscopic procedures, and actually we are performing most of our procedure with robotics. So with robotics we are doing surgeries that are not only urological, but we are treating also endometriosis, adrenalectomy, some kind of sarcomas, it depends of course from the cases, and kidney transplantation and living donor nephrectomy. So this is what happened with the COVID disease. We are actually performing with the robots only urological cancer and kidney transplantation. All the other procedures are for the moment delayed, and of course some of urological cancer I will show you later. So in my hospital we have a dedicated twin robotic surgery room. So we have two rooms, but it's a single twin room for robotic transplantation. So we still performing a full day of operatory room from Monday to Friday for both rooms. And on Saturday, we are working just with one room for 6 hours from 8 to 2 p.m. We had the reduction since the 15th of March, and in the last month, we still perform 127 robotic interventions. I think that it's quite a lot, and it's an important result. Of course, the main question is, are we doing this safely? This is just an image of a national periodic. In our hospital, all the workers were tested, and 95% of them were negative. Positive patients, of course, were in quarantine at home. And all patients before surgery were tested with a swab, while the workers with just blood tests, with the plasma test, with EGG and DGM. So for elective surgery, for that cases, patients were tested 2 days before. Patients that were coming from emergency department were moved to a filter room in our department, waiting the result of the test. But since the 15th of May, no surgery was performed without having the response of the COVID swab. So, as you probably know, the ERUS group with Professor Motri proposed the recommendation of robotic, which robotic surgery should be performed. We don't have any national guideline, as I told you, because we have a very different situation, region from region. And in Florence, actually, we are performing all that cases that they have a medium to weak recommendation to postpone, and of course urgency. We are just we are delaying functional and benign robotic surgery and robotic radical prostatectomy for low risk, so ISOP 1, and radical nephrectomy, of course, for benign pathologies. As about the other surgical procedures, we are still doing open surgery for urological malignancy. Of course, most of them are done robotically, but we perform 2 or 3 very complicated cases with open surgery, TURB, and we are treating, of course, urological traumas and urinary stones in patients with hydronephrosis and with an increase of creatinine of shock, of course. As about the outpatient department, we are still doing evaluation in oncologic patients. Of course, we are giving all the histologic of the surgical procedure that we are doing. And generally for follow-up, we prefer to call the patients. We are actually starting with a protocol to do a video call with the oncologic patients for follow-up. And probably this will be the future for summer, for patients with benign disease. Of course, it's an extremely difficult topic, and I don't really know if it will be useful, and I don't know if it will be safe for us, because it's extremely difficult to evaluate a patient just with a Skype call. Anyway, we are still doing cystoscopies, and we are doing lithotripsy just in urgent cases in patients with adenephrosis, and prostate biopsies in high-risk patients with a PARAS 5 at MRI. The MRI was generally performed before this period, or with a PSA that were more than 20 nanograms per milliliters. In these last two cases, patients were tested anyway, because there is a higher risk of infect the doctor or the nurse. So I think that I have terminated, and thank you for your attention. And if you have any question, I'm really happy.
Thank you very much, Andrea. We have also Dr. Francesco CURTO from Italy. He is working in Sicily. Dr.
Hello?
Francesco?
Yes, I listen to you. Do you hear me?
Yes, it's very clear. We're going to be very useful also if you can talk about your situation and give some advices and recommendations, and then we can open for the questions of the audience.
Okay, in Sicily, I live in Sicily, in Palermo. The situation is quite different from Florence, because we had very few cases of COVID patients. So we continue to operate, but we perform just oncologic case and emergency case. Now, from 15 of April, we can do also benign pathology, but the most urgent case. So in this period, we continued our activity with the oncologic case, and we performed about 100 laparoscopic case. We don't. We operated also prostate cancer T1C and all the oncologic case. But in Sicily now, today, we have just 8 cases of COVID. So the situation is quite going well.
Okay, thank you very much, Dr. Francesco. Ana Carolina.
We have some questions from the chat. Can I do it right now?
Yes, yes.
Okay, so
sure.
Dr. Igor Veras asked about the management of intermediate prostate cancer, if if changed with COVID, with the COVID scenario.
Dr. Andrea, Dr. Francesco, yes, did you listen the question?
Yes,
yes.
the question.
I completely understood. Thank you.
Yeah, okay.
Thank you. In our hospital, the situation for patients with intermediate prostate cancer didn't change at all. The main problem right now is about MRI, because of course the MRI is, the MRI of prostate is not possible right now, because the slots are all closed and just for patients with emergencies, and most of the radiologists are now working for COVID patients, and also in private hospital and I mean, private healthcare centers, they are not working with radiodiagnostics. So there are some concern about prostate cancer diagnosis, and patients with PSA raising probably can have a delayed diagnosis. So I think that the problem is not, it's difficult to speak about the intermediate prostate cancer more than the high risk prostate cancer. The big problem now is to make diagnosis, and that is true also probably for renal cell carcinoma patients and for bladder cancer patients if the CT, the MRI, or the cystoscopies are not available anymore. I don't know what you think. What do you think about?
I think that the point of the question is postpone a surgery in an intermediate prostate cancer risk, or maybe do a neoadjuvant hormone therapy to delay a surgery, for example.
Well, I would never do a hormone therapy for intermediate prostate cancer. We are doing robotic surgery for intermediate prostate cancer, and we are currently running a trial for high risk prostate cancer. So we are delaying surgery for high risk prostate cancer, and these patients are currently treated with hormone therapy, but just for high risk prostate cancer. We are still doing robotic surgery for intermediate prostate cancer.
Andrea, I would like to ask you if parents are admitted in the hospital or no.
No, we don't admit parents. We usually call them after surgery and every day, but they can come just to leave the patients, and they come at the moment of the discharge.
Okay. Do you have some?
Sorry. You can say.
Do you have some situation where the parents are admitted or no, completely?
Not really, because also in the outpatients, only patients can get in.
Okay.
And it's difficult because
we have a similar situation.
Wives are very important to collect the anamnesis.
I think Dr. Fabio Tavra, he'd like to do a question.
Oh, hi there. Thank you very much for the information. I'm a pathologist, and I heard the French colleagues is still doing kidney surgeries. So I have a couple questions. First, are you guys doing swab PCR tests before biopsies as well? And also, are you submitting frozen sections for pathology, or is it not allowed during COVID epidemics? Because you are getting some specimens here, and it says suspected COVID, but we just keep them informally for 48 hours, but we don't know how to do them. If they are frozen sections, they come fresh to the lab, and sometimes it's hard to see what to do with them. I'm not sure if he's still here.
Reply? Or
yeah.
Well, we are doing the swab test, the PCR swab to all the patients.
Even biopsy or just
also for biopsies, yes.
Oh,
and
okay. And how about frozen sections?
Our pathologists are not accepting anymore frozen section in patients that didn't do the swab. Also, for this reason, we are doing the test before the prostate biopsies. Yeah.
And I assume autopsies are not performed as well in the hospital for any patients?
Sorry,
autopsies? Is the hospital performing any autopsies in the hospital or not?
Yes, I think so.
Okay.
I don't really know. how they are doing the autopsies right now. Sorry about that.
Okay, thank you.
We have other question from Dr. Ulysses about kidney cancer. The question is, if you have a lesion, for example, a T1B, that would go to a partial nephrectomy, but after 2 or 3 months later, maybe you cannot go to a partial nephrectomy. How can you imagine this situation?
But as I told you, we are currently doing surgery also for all kind of renal cell carcinoma. We are just delaying the PT1A cases, but we are still treating the PT1B, and I think that it's really important to do them. If you have an organization and you can test the patients before. Of course, it depends also from the situation of your region, how many COVID cases you have, how many intensive care beds are free. There are many variables that you have to consider. And also in Florence, the situation 1 month ago was much worse than now. So probably we can move to do also the PT1, the clinical T1 renal tumors in 3 weeks. So also for this reason, I think that it's really hard to give absolute recommendations.
Andrea,
Yeah,
I have a question for Andrea. You showed a slide where 95% of workers in the hospital are negative, but all the people working in the hospital are tested just one time, or every 1 week, every 2 weeks?
Thank you for the question, Francesco. This is a very important question. Actually, the workers were tested just once, and just my wife is an anesthesiologist, and now she's working in my hospital. And for example, she was working in surgery, and then she moved to a COVID department, and she worked there for 3 weeks. And she told me that all the anesthesiologists that they were moving from the COVID department to another department, a non-COVID department, they were tested again, but just them. And most of them did then without speaking with the work medicine. I mean, just for their own choice. So the management was not really brilliant in our hospital, but generally they were tested just once.
That's something very important about the test. Our situation in Brazil is a kind of difficult because here we don't have enough tests. So now we test only very sick patients. So I think now we are facing the worst, start facing the worst part of the outbreak. And the problem is because we don't have enough tests. Also, we don't have enough PPE for the health care professionals. In Italy, you have enough PPE?
You want to reply, Francesco, first, or?
Yes. I know that in my hospital we have PPE, but I haven't seen it. I haven't seen it. But we really have no case of COVID, so we have a very lucky situation.
And for a surgery in a patient COVID-free, how kind of PPE you use?
In the surgery, we have only the surgical mask, and of course the gloves, what you usually have. But the main problem is not during surgery. I think for the DP for urologists, the main problem is when you are doing outpatients. Because, for example, when you are doing cystoscopies, you see 10 patients that are not tested. And the same is for oncologic outpatient visits. And you don't know if they are COVID-free or not. And we are visiting them just with a surgical mask. I usually have the surgical mask dressed, always with me. But we know that it's not enough. But of course, if the patient has the mask, you have the mask, the risk is reduced. We usually wash our hands like thousands of times. We know that it's not 100% safe situation, but we are still trying to work and try to manage it.
Dr. Karine Trindade, I think she has a question.
Yes. Hi, Dr. Andrea and Dr. Francesco. It's a pleasure to welcome you in our weekly meeting. I have a question about non-invasive bladder cancer, the high-grade patients. It's about cystoscopies. If you are delaying the cystoscopies or spacing out in patients who are on maintenance or who finish the induction, how do you manage these patients?
Well, thank you, Karin, for the very important question and topic. I don't know if you read the European Urology recommendation about BCG from the France group of, I think it was Professor Rupré. Yes, Professor Rupré. And the actual European recommendation is to do the induction BCG while delaying the maintenance BCG. In our center, we are currently doing the normal follow-up for high-grade bladder cancer. And we are doing exactly the induction, but for the moment, we are delaying the maintenance BCG. Francesco, how do you manage high-grade non-muscle invasive bladder cancer patients?
Francisco Curto, Dr. Francisco Curto. Did you listen? I think no. Yes. Dr. Fabio Nasser, I think he has a question also.
Fabio, we can't listen.
Fabio?
Your microphone, I think it's off.
Hello, are you listening to me? Is that right?
Yes.
Yes.
All right.
So thank you, Andrea, for having the time to spend with us. So as I understand, you're moving from a very difficult time. Now things are getting better. You had used the tests like to perform surgery safely and to do all the manage of the cancer patients safely. Now you're just about to open more of the indications and the procedures they're about to do. So there's going to be a lot of exposure for many patients and for the medical staff. So my question is, how are you planning, or is any measures they're about to implement to, in the larger scale, to do the care safely for those many more patients. For example, you're going to have many more patients with imaging. They're going to have a lot more outpatients. So, do you see any change in your management? How are you preparing for those patients that are about to increase?
Hi Fabio, nice to meet you. Thank you for your question. Well, actually, the situation is not that different from last month. We are currently running the same indication for surgery and for our patients, and probably we will postpone all benign surgery until the first days of September. This is what my boss, the chairman of my department, said, but we don't know what it will happen, and it also depends from the COVID epidemiologics. This is a big problem, and we are really worried, as I told you before, about diagnostics. The main problem is probably not doing the biopsies, but doing the MRI. Because if you can select the patients, of course, the number of biopsies is a little bit less, is for sure lower. But we have, for the moment, around from 4 to 6 months of waiting for MRI for prostate cancer. So we don't really know how to manage it. We don't have any solution.
Do you use telemedicine or something with the web services to the patients? Or
we will start soon. They are running a protocol about telemedicine, and probably we will start from the half of May. But the problem is that the average of the Italian population is very high, and we have a lot of urological patients that are more than 75. So there are some patients that, of course, they have a family that they can help them with the telemedicine. But the biggest problem is that from the half of May, most of people will go back working. And if they go to work, they are at an increased risk of COVID. So they cannot stay with their parents that are 85. So the elderly population will be alone at home. It's not simple.
Yeah,
it's not simple. But I mean, before the outbreak, you usually do you do telemedicine in Italy before the outbreak?
No, never. We've never experienced that.
We have a final question on chat.
Can I make a question to you?
Yeah, sure.
You have experience with telemedicine in Brazil?
In fact, in Brazil, there is a lot of discussion about the telemedicine. Before the outbreak, it was not allowed yet, but now, just during the outbreak, the government allowed to do. But there are so many questions. It's not completely regularly. So some doctors start to do, but I mean, not everybody doing right now. I don't know if someone would like to say something about this. Dr. Ariel, he is with us. Dr. Ariel has experience in telemedicine. Are you there, Dr. Ariel?
Yes, I'm here.
Yeah, you can say something about the telemedicine.
Oh, well, what exactly what you want me to say? Because well, actually, the thing about my experience with telemedicine, we have a very strict rules that have been changed because of the coronavirus situation here in Brazil. They have been become more flexible because of this situation. I think that after the pandemia resolves, things are gonna be reanalyzed, and then I think that authorities are gonna have to try to understand how things are gonna have to be done. I'm really sorry because I'm at home with my kids, so I'm not in a proper dress code for this meeting, but I am with my kids. So
thank you, Dr. Yao. It's nice. Sorry, I didn't.
So I think we are in a very specific moment for the thing of the use of the telemedicine. In one way, I think this is a good opportunity to discuss the thing of the telemedicine, because I think that Brazil opened for the rules to become more flexible, and so we see it as an opportunity to explore it. But after we're gonna have to see how to deal with it. I think that we can't go back to where we were, because we didn't explore it in a very useful way in the past. Rules were very strict. I think it was very, they were so strict, we didn't explore technology before. And they were strict for a reason, because it was not very, it was used in a bad manner in Brazil. It was not very explored in a good way in Brazil. So, but I think this crisis made it open, and I think that after the crisis, we're going to have a good development of technology, and I think that technology is going to be very developed during this period. And I think that if we use regulations together with technology to develop telemedicine for use in this situation, I think we're gonna have a good outcome at the end of it. I think we're gonna have a good outcome.
So thank you very much. I'd like to ask Dr. Andrea Mari if you'd like to say your final words. Now is in Fortaleza is 6 p.m. I know that in Florence is
time to go to
around
bed.
11. Yes. So you can say your final words.
No, I just would like to thank you. It was a real pleasure to share information and with you, and I think it's the most important thing to do, because we are trying to share our ideas. There are, of course, experienced persons that are giving recommendation, but it's a extremely unique situation, and it's very difficult to have just one truth. Most of the decisions that are now taken in the hospital are just based on a common sense, and are trying to reduce the mortality of our patients and work safely. But of course, any good idea is more than welcome. So
thank you Dr. Francesco Curto. Would you like to say your final words? Are you still there with us?
Yes, I am with you.
Yes.
Yes, thank you very much, and I hope to see you again very soon.
Thank you very much. Ulysses?
I can listen very well. I say goodbye to everyone, especially to you, to Clovis, that I have seen, to all the participants.
Thank you very much.
Thank you.
Ulysses,
We're looking forward to seeing you in Italy back.
For sure.
Soon, I hope.
One last question
Bye.
about kidney transplant. You said that kidney transplant was going normally there. Is it operating normally, or only those cases that has no venous access for dialysis? How are the kidney transplants going?
In Florence, we are still doing renal transplantations just for death donors. In patients who are doing dialysis mainly, I think that the patients that are not doing dialysis are quite low. So I think that they are all patients with a ESRD.
Okay, because here, even patients that are doing well in dialysis, they are not going to transplant. Because here we have a big problem with testing. So we cannot test the donors, even the deceased donors, we cannot test them. So it's a risk for our patients to do kidney transplant.
Yes, for sure. And another big question is that about the test, because the sensibility of the swab, of the PCR on the swab or oropharyngeal swab, is not that high. So if the patient is positive, is a false negative. Of course, after the transplantation, the immunological defense is very low. So that's a good point.
Thank you very much.
So, thank you very much. Nós vamos encerrar a reunião. Muito obrigado aí a todos os amigos, a todos que compareceram, que estiveram aqui. Acho que foi um momento importante aí de discussão e não sei se o Dr. Rômulo, como chefe do serviço, quer finalizar e dizer algumas palavras. Está aberto aí, Dr. Rômulo, e aí depois a gente encerra.
Não, só parabenizar, agradecer a presença de todos. And thank you all that came here to our section. Obrigado.
Um grande abraço a todos e tudo de bom. Se cuidem.
Thank you. Bye-bye.
Thank you, Andrea. Bye-bye.